Thank you for inviting me to talk today. I've never given a talk to an Indian medical school. It's the first time for me. So it's a pleasure to
Really?
be here. And yeah, very excited to hopefully tell you guys all a little bit about expedition medicine and some of the opportunities in medicine that you might not have come across before. Shall we get started? It's nearly 5 past. Um, Fine. So you can all hear me okay, and you can see the slides, is that right?
Yes, sir.
Excellent. So expedition medicine, it's something that I didn't really know existed until a few years ago. I wasn't told about it when I was at medical school. I sort of discovered it a little bit by accident. And you might be wondering, what on earth is expedition medicine? And the title of the talk is Traveling and Medicine Combined. And it really is an opportunity to travel. In the last few years, I have been to Mount Kilimanjaro, and this was my home on the mountain for about 3 weeks. I was sleeping in this tent, and I was looking after groups of university students that were trekking up to the summit of Kilimanjaro, trying to reach the summit and helping them do this successfully. So that was my home for about 3 weeks with one other doctor, and we had a small team. There was a cook, a couple of porters, a guide, and that was my first job as an expedition doctor. Since then, I've been to the jungle in Cambodia, the Sahara Desert, in Ecuador to the volcanoes there, Mount Everest on a trek to base camp, Dharamsala, which was an absolutely beautiful region in the north of India. I don't know if any of you have had a chance to go. Leh, up in also in the Ladakh region, up in the north of India, and Mount Toubkal in Morocco, which was an expedition I did just after coming back from the Sahara Desert. And this is a video of us just getting near to the summit. As you can see, the conditions are quite windy. It was quite cold that day. It was about minus 20 degrees Celsius. And and I've been to Pakistan as well last summer, up to K2 base camp. So really over the last few years, expedition medicine has given me the opportunity to travel all over the world. So from my initial expedition medicine course that I did in Chamonix, to Tanzania, to Morocco, to the Himalayas multiple times. And it's really been this incredible opportunity to use medicine outside of the four walls of the hospital, and to use medicine as an opportunity to travel the world, but also to become a better doctor when I am in the hospital. So with expedition medicine, you really have to remember that it is something that goes alongside your career. You can't be just an expedition doctor. And the reasons for that are several. But essentially, most of the work you do as an expedition doctor is voluntary, or they will cover your expenses. It's quite hard to find paid work as an expedition doctor. It does exist, but the opportunities are fairly few and far between. So that's one of the reasons why you couldn't just be an expedition doctor and not do any hospital medicine. The other reason is because actually, when you're on an expedition, a lot of the work you do as a doctor comes before the expedition, and it will involve doing risk assessments of your participants and planning the expedition so that if there is a problem, you know what treatments you can give them and how you're going to evacuate them to the nearest hospital. However, if you're on expedition only as a doctor, it means that you won't actually see clinical pathology very often. Yes, you'll see altitude sickness or dehydration and things like that, but you're there as a doctor to deal with the unexpected. So if someone dislocates their shoulder on expedition, and you aren't you aren't reducing dislocated shoulders on a regular basis in the emergency department, you're going to not be a very effective doctor if it's not a skill that you're used to doing. And so to get the density of exposure to clinical skills, you still need to work in, for example, a general practice setting or in the emergency department and have that exposure of day-to-day medicine that you can only get through being a doctor within the hospital. However, the expedition medicine can go very nicely alongside that as an opportunity to get outside of the hospital, to explore the world, and to practice medicine in a remote environment where all of your usual support safety networks and investigations and imaging and all of that isn't necessarily possible. So if this all sounds like a really cool idea and you want to hear more, please do take a moment to pop onto Instagram and give me a follow. It's at expedition_doctor. So on my Instagram, I'm regularly posting about places I've been to, photographs from different expeditions. I often do, maybe once a week, I'll do a case on my Instagram story. So I'll take you through a whole bunch of questions that's interactive, and it gives you an opportunity to learn something about medicine. And I usually focus it on either expedition medicine or emergency medicine, because I work in the emergency department the rest of the time. So for example, my Instagram story from the other day, it was a case of stepping on a sea urchin, which are these spiky creatures that live in the ocean, and if you step on it, it creates a very painful sting, and it's something you might have to deal with if you are on an expedition in an island, for example. A couple of weeks before that, I was doing a case on ectopic pregnancy, and before that, a case on ECGs. And you can find my old cases under the highlights section in my Instagram. So if you do find this sort of topic interesting, please do head over to at expedition_doctor and give me a follow there. And so I've talked a bit about the traveling, had the opportunity to go all over the world, as you've seen. But I wanted to talk a little bit about the actual medicine that's involved in expedition medicine and what you might have to do as an expedition doctor. So some of the things to think about are essentially the medical conditions that can arise on expedition. And essentially anything that can happen at sea level, on the ground in your usual home environment, any of these things can happen when you're on an expedition as well. So whether that's a UTI, a urinary tract infection, whether it's a migraine, if it's appendicitis, gastroenteritis, anything like that, all of this pathology can happen on expedition, and in fact is more likely to happen on expedition compared to in day-to-day life. And there's various reasons for that, but some of them would be the fact that you might be physically exhausted, you're not sleeping very well if you're in a tent, you might be in a confined living space. So if normally, if normally on expedition you're on camping, there might be many of you all camping in fairly small space, so it increases risk of transmission of infectious diseases, whether that is something like meningitis or whether it's something like an infectious gastroenteritis. And so these are all things you have to bear in mind. And then if you're somewhere like the desert or at high altitude, you can be much more prone to dehydration. So all of these factors in combination mean that you are at higher risk of your usual pathologies, such as gastroenteritis and meningitis and things like this, as I mentioned. However, there are also further pathologies that come about as a result of being on expedition. And these are from the unique environments you find on the expedition you're on. So if you're at a high altitude expedition, so for example, this picture is taken from Mount Cotopaxi, which is the the second highest volcano in Ecuador. And it is, in fact, one of the highest places on the planet because of the way the Earth's crust bulges at the middle. This point is actually closer to space than Mount Everest, even if it's not quite as high above sea level. But anyway, so this was a picture coming down from the summit, which you can see in the background. And this is one of our guides coming down over the glacier. And it's quite nice because it demonstrates some of the unique environmental conditions you might find on a high altitude expedition. So you've got freezing conditions during the night. If you're climbing the summit, during the night, temperatures might drop to as low as -20, -30. and then you have wind chill on top of that. So it can get really, really cold. Then when the sun comes up, you're getting a very high UV exposure. The atmosphere is thinner. There's a lot of snow on the ground, which reflects up UV light back up to the face. So there's a lot of UV light as well. You might be physically exhausted. So when you're up at altitude, your quality of sleep is reduced. There's multiple reasons. Partly it might be windy, it might be cold, it's noisy, you're not used to sleeping in a sleeping bag and in a tent. But also as you go up in altitude, it's easy to develop something called high altitude periodic breathing, which is a type of breathing pattern that looks the same as something called Cheyne-Stokes respiration you might have heard of. And essentially it's because the atmospheric oxygen level is so low at altitude, your body becomes reliant on a hypoxic drive. And so as you fall asleep, you're not responding in the same way to the carbon dioxide buildup that you would down below. And you actually develop a Cheyne-Stokes respiration pattern where you have brief periods of apnea every couple of minutes, which can disturb your sleep. So this is another reason, another environmental factor when you're on expedition. Again, it's difficult to keep as clean as you would. You can't have a daily shower, for example, and you might be quite dehydrated, especially when you go to altitude. Your body diureses quite dramatically as a way of concentrating the blood to increase the amount of hemoglobin you have in order to increase your body's ability to use oxygen. So these are some of the more unique environments you might find on expedition. Just coming back to this previous slide, if you think about a different environment such as the desert, again, you've got high UV exposure, poor personal hygiene, dehydration. It's in the jungle. You're going to be prone to heat-related illnesses because the high humidity means your sweat can't evaporate properly, and it's much more hard to dissipate heat from that you're building up through working and through physically exerting yourself. So coming back to altitude, I thought I might just run through a few sort of specifics. So India is obviously an incredible country with a huge range of environments. You've got jungle in the middle, you've got the coastal regions, you've got the north of India where you've got all of the Himalayas. And I've been lucky enough to go to the Indian Himalayas twice now. I went to Dharamsala with a company called Just Challenge, which organise essentially trekking adventure trips for corporate groups. So this was a trip for Barclays Asia Pacific, and we had 50, 60 bankers on a mini expedition up in Dharamsala in the Indian Himalayas. And on this trip, we were sort of in the high altitude to very high altitude range. I think our maximum altitude was about 3,000 meters. And we essentially were just trekking through the foothills of the Indian Himalayas for a few days, and it was absolutely stunning. Another trip I've done to the Indian Himalayas was in the Sahara Valley. So you fly into Leh, which is already about 3,600 meters, so it's very high altitude. And we stayed there to acclimatize for a while before moving up to the Sahara Valley, which is just over the Tanglang La, which is the second highest drivable road in the world. And it's an absolutely stunning part of the world. I've got some, hopefully some pictures later in the slideshow. And this was a trip with British Exploring Society, which is a charity based in London in the Royal Geographical Society. And they take young people, so 16 to 25-year-olds, they take them on expeditions around the world, so to the Amazon rainforest, to the Indian Himalayas, to the Yukon in Canada. And they use this as an opportunity for young people to develop their leadership skills, their outdoor skills, and give them a really memorable experience. But because they are going to remote places where there isn't necessarily any medical facilities, there are sometimes needs for a doctor to be present. And so on all of their expeditions, they take a doctor or sometimes several doctors. So on our trip to the Sahara Valley, we had 5 doctors because the expedition was split into 4 groups, and we had 1 doctor as sort of a reserve in case anyone needed it to be evacuated. And Devashish has just said that the world's highest motorable road goes through Al Ladakh, the Kardung La. That's very true. That was nearby, and it's just an absolutely stunning region. So if anyone does get the chance to head up into the north of India, into the Himalayas, up there, it's absolutely worth it. It is stunning. So moving higher again, obviously you've got all of these regions within India. You get extremely high altitude, so that's like on Mount Kilimanjaro. And then once you go above 8,000 meters, that's something known as the death zone. And that's where Mount Everest, Kachingchunga, Cho-Oyo, K2, all of these mountains stand in the death zone. There's a really, really good chap on Instagram. I'll type his handle in the chat, who is worth following as well, at Nims Dai. This guy, he summited all 14 of the mountains above 8,000 meters last year, and he did it in 6 months, which is absolutely mind-blowing. The previous record was 8.5 years. So he's definitely a chap worth following if you're into your mountaineering. So as you can see, as you get higher, the oxygen level gets lower and lower. And this is essentially what leads to the development of altitude sickness. So I thought, as I'm personally quite interested in high altitude expedition medicine, I thought I'll just talk a little bit about that and go through a quick case with you guys to sort of showcase some of the medical work you might be thinking about on expedition. So as the picture you see in the background there, that's actually taken from the summit of Mount Toubkal in Morocco, which is the highest mountain in North Africa. It's 4,167 meters. So as you go higher, the partial pressure of oxygen in the air, which is obviously the air you're breathing in, gets lower. And that means the partial pressure of oxygen in your alveoli decreases as well. And this makes it harder for your body to get the oxygen it needs from the air you're breathing in. And this can cause altitude sickness. And that altitude sickness comes in 3 forms. So I'm expecting this probably hasn't come up in your medical syllabus so far. So I'm going to go through some of the basics, but apologies if you guys are experts on altitude sickness, your curriculum might be a little bit different to what we had in Cambridge. But essentially altitude sickness is split into 3 categories. You've got acute mountain sickness, which is the most common. You've got high altitude cerebral edema, HACE, and you've got high altitude pulmonary edema, HAPE. So in American English, they spell edema without the O, hence the HACE and HAPE. You might sometimes see it referred to as HACO and HAPO, but not very often. Essentially, acute mountain sickness is a set of symptoms that occur when you go up to altitudes, usually above 2,500 meters, and it's characterized by headaches, lethargy, dizziness, nausea, loss of appetite, sometimes vomiting. Poor sleep used to be one of the diagnostic criteria, but that's come out because they recognize that pretty much everyone sleeps badly at altitude anyway, regardless of whether they have acute mountain sickness. And acute mountain sickness by itself is unpleasant, and it's not dangerous though. However, it is a warning sign that you shouldn't carry on going up the mountain. You should wait for your body to acclimatize or head back down to allow your body to acclimatize further before carrying on. And the reason is because if you leave the acute mountain sickness and you ignore it and you keep pushing up, you're at risk of developing something called high altitude cerebral edema, which is where the brain actually starts to swell as a result of the lack of oxygen. And you might remember your Monroe-Kelly doctrine, which says that the skull vault is a closed fixed volume. It's non-expandable. And so if you've got increasing volume of something within the skull vault, essentially there's no room for it to expand, and so the pressure goes up. So as your ventricles start to collapse, then the venous return starts to become impaired, and eventually, if it's severe, you can have coning, which is where the brainstem gets squeezed out through the foramen magnum at the skull base, which is obviously a terminal event, and which is why high altitude cerebral edema is a life-threatening situation. And is not something that you want to find yourself in at altitude, but it is very common. Well, it's not very common. It happens not not infrequently. I've seen about 4 cases of high altitude cerebral edema myself, but it always necessitates evacuation and oxygen treatment. So the way to find high altitude cerebral edema is one of your participants. They might have been having some symptoms of acute mountain sickness. They might have been having some headaches, some loss of appetite, feeling lethargic and dizzy. And the thing that sets high altitude cerebral edema apart from acute mountain sickness is the symptoms plus an actual hard neurological finding on examination. So this might be ataxia, and typically it'll be a truncal ataxia. So the legs seem to be okay, but the upper body is swaying side to side, very similar to what a drunk person might look like. They might have a change in mental state. So that one of the guys we had in Sahara Valley, actually, who in India, who developed high altitude cerebral edema, he went from being really quite okay in the morning. He woke up, had a bit of a headache, didn't fancy breakfast, to about an hour and a half later, vomiting nonstop, so ataxic he couldn't stand up by himself, and was so confused he didn't even know where he was, what country he was in. He couldn't remember his birthday. So it can happen quite quickly. Other neurological findings you might have are a nystagmus, or even a ocular gaze palsy. For example, the sixth cranial nerve and the third cranial nerve can sometimes become involved if it's severe high altitude cerebral edema. You might remember from your neuroanatomy, the ocular motor nerve, which is your CN3, and your abducens nerve, which is CN6, have quite a long path coming out from the brainstem up to the output in the ocular muscles. And so these 2 nerves are fairly early to be affected when your pressure within your skull increases. And so you might see that with other causes of cerebral edema as well, not related to high altitude. Often the 6th nerve and 3rd nerve are ones that get affected quite early on. So essentially, symptoms of AMS plus a neurological finding is your high altitude cerebral edema. And as I mentioned, it's a life-threatening emergency and always necessitates evacuation. High altitude pulmonary edema is the other form of altitude sickness, the 3rd one that we haven't talked about yet. And it is kind of separate to AMS and HACE, which are linked. HAPE can happen independently of whether someone has acute mountain sickness or not. And essentially, it's, as it sounds, it's when you get fluid buildup in the lungs. It presents quite similarly to cardiogenic pulmonary edema, where you're getting short of breath at rest. You get orthopnea, you can get so shortness of breath lying flat, paroxysmal nocturnal dyspnea, which is where you wake up in the night gasping for breath. You can get a cough. Initially, it's a dry, tickly cough, but as it becomes more severe, it becomes productive of pink, frothy sputum. So these are all symptoms that hopefully will be fairly familiar with you, to you from things like cardiogenic pulmonary edema. However, high altitude pulmonary edema happens due to the lack of oxygen, causing an inflammatory response in the lungs and a buildup of fluid. And again, it's life-threatening. So when someone goes from being comfortable to developing and showing signs of pulmonary edema, and they are getting very out of breath, struggling to keep up with the group, and they are coughing every time they're lying flat and their oxygen saturations are dropping, this is a life-threatening situation again, and is one that necessitates evacuation and descent, because the treatment for all altitude sickness is descend to increase the amount of oxygen. And if you can't descend, it's to give them oxygen by another means, which we'll come on to in a minute. So these are, it might be of interest to you, the actual saturations that you measure on a person when you're at, say, 4,000 meters. A normal, healthy person who's doing well without altitude sickness might be recording an oxygen saturation of about 84%. So that's quite normal. You might see in a lot of my medical notes, it will be, respiratory rate 28, saturations, oxygen, 82%, no concerns. So that's the kind of thing that would obviously land someone in intensive care in a usual hospital setting. But when you're at altitude, the numbers by themselves don't necessarily mean much. You need to take it in context of how are they doing clinically, and how are those numbers compared to everyone else's numbers in the group. So, and you obviously can't put someone just through an ultrasound, through a CT scanner or a chest x-ray. So it's quite interesting. You have to use a lot of your clinical skills. So the treatment is, as I mentioned, for altitude sickness, it's always to descend. So this was descending from Mount Toubkal. Someone drawing this. This was descending from Mount Toubkal. Absolutely glorious weather. Well, cold, but very nice. And I don't know what all of that scribble is on the screen. I'm very sorry. Let's see if I can clear it. There we go. That's great. And other descent options might be by helicopter, for example. So this is when we were evacuating someone off the slopes of Mount Kilimanjaro. And sometimes the treatment, the descent option is on a stretcher. So again, these are stretchers that you find on Mount Kilimanjaro, and they're all sort of concentrated in one particular area. And if someone's being evacuated, they get wrapped up in a sleeping bag, put on a load of padding, and put on one of these stretchers, which have one wheel in the middle and have one essentially local person or some of the team on each corner to essentially cart them down off the side of the mountain. So essentially, if someone's showing signs of high altitude cerebral edema or pulmonary edema, you really need to get them to descend the mountain to increase the amount of oxygen that they're breathing in and hopefully improve their condition. And they are all reversible, but they need to be treated quickly, otherwise they can be life-threatening. So as an expedition doctor, part of your job will be to recognize if someone is at risk of high altitude cerebral edema or pulmonary edema and try to mitigate that risk and reduce their chance of developing these life-threatening conditions. And that might be by spending an extra couple of days at a set altitude before you go on. It might be by making someone rest for a couple of days, for example. And however, part of the other decision making you have is to decide when someone is showing these signs and needs to descend. But things get interesting when you can't descend. And that might be because it's the middle of the night and the helicopters aren't flying. It might be because for example, in Pakistan, in the north of India, there's military tensions there and it's a militarized zone. So you can't have a normal helicopter evacuation. You have to use a military helicopter, which, as you can imagine, it might be a little bit difficult if you are in the Himalayas and I'm getting on the satellite phone to the insurance company who's calling the UK to then call the UK Indian embassy to call back to India to then mobilize an Indian military helicopter to go into the Himalayas. As you can imagine, it's a difficult process. So sometimes the weather might be too bad to allow an evacuation, or sometimes maybe someone's broken their leg and there's not enough people to help carry them out. And that's when things get more interesting as a doctor. So this was an evacuation we were doing on Kilimanjaro in the middle of the night. It was about 2 o'clock in the morning. The participant was on the stretcher. You can sort of vaguely see it. I'll play that again. You can see it just on the left there, that wheel. And he had high altitude pulmonary edema and his SATs were 46% at this point. And so we decided we had to get him down the mountain, and it was 2 in the morning. And so obviously we couldn't get a helicopter, but luckily the weather was good. We had access to a big team and a stretcher and we could get him down the mountain. But sometimes you can't descend. And that's where things become a little bit more interesting as a doctor. You have to do a bit more. And so you've got a few tricks up your sleeve. You've got a few things that you can do to help. Essentially, you can take oxygen with you. So administering oxygen kind of replicates descent. You're improving the amount of oxygen they're breathing in, can hopefully slow down the process of edema. So it's very important to have oxygen if you're on a remote expedition or a high altitude expedition. Then you've got some drugs that you can use. So dexamethasone is the drug of choice for high altitude cerebral edema to try and reduce some of the swelling. You've got nifedipine, which is a tablet. It's a pulmonary vasodilator. So if you've got high altitude pulmonary edema, giving nifedipine can increase the vasodilation of the pulmonary blood vessels and increase the amount of oxygenation. that is happening as within the lungs, so that can buy you some time. Again, these aren't substitutes for descent. It's just a way of buying time before you descend. And then there's diamox, which you can see there, which is also called acetazolamide, and that is a carbonic anhydrase inhibitor, which means you essentially urinate out bicarbonate, which acidifies your blood, and in response, your body breathes quicker to try and blow out more carbon dioxide, but as a result, also increases the amount of oxygen you're getting. So there's a few other drugs in there. I've got some adrenaline and chlorphenamine in case of any allergic reactions, ondansetron as an anti-sickness medication, and diclofenac as a painkiller. And you can see Penthrox there, which is a medication that is really, really, really cool. I don't know if you guys have it in India. We just got it in the UK in the last couple of years. It's been available in Australia since the 1980s. But it's essentially an inhalational anesthetic drug. So you just breathe it in through a little inhaler and it creates incredible pain relief, and is very quick on and off, doesn't cause people to undergo full anesthetic. It's just a very good procedural analgesia, similar to using laughing gas or nitrous oxide, but much, much, much more portable. As you can see, it's just a tiny vial. So if someone gets stuck under a rock, for example, or dislocates their shoulder, breaks a leg, this is a fantastic drug for essentially giving them some really strong pain relief while you do a painful procedure. On the right over here, you can see what's known as a portable altitude chamber or a gamma bag. So if you're somewhere very remote, such as in the north of Pakistan, then it can be useful to have one of these as part of your base camp medical kit. And essentially, if someone's got a severe altitude sickness and you've got absolutely no way of descending and you don't have any oxygen available or you're running out, you can put someone inside this altitude chamber and zip it up and use that foot pump to inflate it. And what that does is it creates a higher pressure within that chamber and essentially can halve someone's effective altitude. So it's a quick way of simulating descent in someone who's very, very unwell. But again, it's just a way of buying time. That person still needs to go down. So this is the general sort of approach to evacuating someone. It's to inform your expedition leader, calling for help, descending as soon as possible, descending as far as possible, giving oxygen, giving medication. The picture here is we're evacuating someone with high altitude cerebral edema in the Indian Himalayas in the Sahara Valley. It is absolutely beautiful day. We were evacuating him. This was at 5,100 meters. So, and you can see we've all got a lot of kit on our backs. So it's absolutely exhausting. We needed about 14 people to evacuate him. And he was only going, I think it was 1 kilometer, but it took us about 4 hours because of how much work it is to carry something at that altitude. And during that time, an electrical storm came in. We then had to cross a glacial river, and that was only to get us back to the base camp at 4,800 meters. And then we had to go over the Tanglang La back to Leh to evacuate him. But he did very, very well. So before we move on, I just thought I'll go through a very quick case. I don't have any way of getting you guys to do interactive questions, unfortunately. But I thought I'd just talk through a case that I've prepared. So this is a photo from the Gondogoro La, which is in northern Pakistan, just about 30, 40 kilometers west of the Indian border, and it's near K2 base camp. And it was about 3 o'clock in the morning. We were sort of going over the pass at 5,400 meters altitude, and the climber in front looks unsteady. So you might remember that slide earlier. So the approximate amount of oxygen at this altitude compared to sea level. A good rule of thumb is 5,000 meters is about 50%. So it's worth doing that. It's worth noting that these percentages on the right, 21, 15.75, 10.5, they aren't actually accurate. They're more equivalent. So the oxygen percentage stays the same whether you're at sea level or the top of Everest. It's always 21%. It's just that the pressure reduces, so 21% of a fewer number of molecules in a given space. So these are just the equivalent percentages of what it would be in terms of the oxygen you're receiving compared to sea level. So the answer for this one is C, 50%. And what would you do next? It was funny when I did this slideshow as part of a teaching presentation. Pretty much everyone called for a helicopter. However, it's, all you know so far is that the climber in front of you looks unsteady, and it's the same approach to medicine as you would do in a hospital or in a GP setting. The first step is always to take a history and examine the patient. You don't want to be calling helicopters in the middle of the night in northern Pakistan in a militarized zone before you know that that person actually isn't just feeling a bit tired and wanted, or lost their footing. You need to have a good history and examination to come up with your diagnosis. So in this case, the next step is to take the history and examination and find out a bit more what's going on. So doing that, you find out the history. They've got a terrible headache. They feel exhausted. They're vomiting. So these are the symptoms of acute mountain sickness that I mentioned before: headaches, vomiting, lethargy, dizziness. And we highlighted before the difference between AMS and HACE was the presence of a neurological finding. So that's something you find on examination. And here they appear confused. So they've got a reduced GCS. They're unable to walk in a straight line. So they're ataxic. And they're almost falling over. So we've got someone who's got symptoms of AMS plus neurological signs, which means that gives them a diagnosis of HACE. In this case, you aren't able to get any observations. You're wearing big, thick mittens. You can't expose them. You do take their glove off, but you can't feel a peripheral pulse because your fingers are numb, and the oxygen sats probe isn't picking up a trace because it's too cold. So no observations are possible at this point, which is often true on expedition. So this person has HACE, which we know is a life-threatening emergency, and we need to evacuate them. So this is your situation. You've got someone 5,400 meters, 3 o'clock in the morning. It's minus 20 degrees Celsius. It's windy. You're 9 hours into the climb. You're just 100 meters from the top of the pass, after which the group will descend into the neighboring valley. You don't have any oxygen with you. You don't have a gamma bag with you, but you do have your medical kit. What is the best option? And these are the kind of decisions you have to make as an expedition doctor. You need to decide, are we going to push on to the summit and then descend into the neighboring valley? Or are we going to turn around and descend immediately? Or are we going to give some dexamethasone and then monitor before deciding? Or are we going to call for a helicopter and wait for evacuation? And you could argue for any one of these. And so it's always very situation specific, and it will depend on the team you've got with you and the participant themselves. However, if you think about option A, pushing onto the summit and descending into the neighboring valley, then actually that's got a, you could argue for it, and it depends on how well your team knows what's on the other side. But actually, you might get to the summit, but 100 meters could take you 2 hours or 3 hours in this situation, especially if someone's dizzy and all over the place. It might take 4 hours even, and they might just continue to get worse and worse and worse at every meter they go higher. And also, when you do get to the top and descend into the neighboring valley, you don't know what's on the other side. It might be really dangerous scree slopes. They might need to do quite a technical rope descent. So this is something to bear in mind. Just because you're almost at the summit doesn't mean that's a good reason to just carry on and push on. Giving dexamethasone and then monitoring before deciding, again, it's a possible option, but this person is already showing some clear signs of high altitude cerebral edema. And if you can descend, then that's always your best option. You never want to delay descent for anything else. And calling a helicopter and waiting, you could be waiting there for days and the whole team would have died by hypothermia by then. So essentially your best option in this management is to actually turn around and descend immediately, as disappointing as that might be. Luckily, this is a made-up case, and we actually didn't have to turn around and descend at that point. We did continue and push on, and it was a glorious day the other side, but it was quite technical, and we did have to use ropes to get down. So it's lucky there wasn't anyone who was too unwell. So it's worth just talking very quickly about essentially medical jobs, because you guys, if it's anything like I was told, you get told that you can finish your MBBS, finish your internship, and then you can become a cardiologist, or you can become a surgeon, or you can become a general practitioner, or a plastic surgeon, or a gastroenterologist. You get told that these are your career options. And you have to go through a training pathway and become a specialist. And while that's definitely the traditional training pathway, I would like to just help make sure that you guys are aware that there are other opportunities in medicine. So whether that is just locuming, so that's working as a non-contracted, non-training option, that's something that's possible in the UK. I'm not sure if it is in India too. Junior clinical fellow jobs in the UK, we have lots of people who come over from India doing these jobs, which are essentially standalone contracts with a hospital that aren't part of an official training pathway, but essentially can get you a job in a hospital somewhere. If you're interested in research, once you've got your MBBS and you've done your internship years, you are a qualified doctor. You can go and start looking into the world of research. And I had my housemate from last year spent 2 years doing neurology research and was doing incredible stuff into ALS, amyotrophic lateral sclerosis, and treatment options for that using gene therapy. But then, as a doctor, you've got an amazing skill set. You've shown that you've got the ability to learn and to retain information and apply yourself in unfamiliar situations, and are a good problem solver. And so if you're interested in management and consulting, there are loads of opportunities within other companies, more corporate situations that are always looking for doctors. Then there's a whole field of medicine. There's lots of it on Instagram at the moment of doctors who are more interested in lifestyle and nutrition, aesthetics and wellness. So if you've got a passion for one of these, you can do diplomas in lifestyle medicine, diplomas in wellness. There's all sorts of opportunities that don't necessarily involve staying within the hospital walls, that allow you to get out onto social media, have other sorts of consultations and do something a little bit different. And lastly, of course, there's the world of extreme medicine, and that encompasses expedition medicine, which is what we've been talking about. You've got aerospace medicine, so NASA, the space agency, the European Space Agency, these agencies all employ doctors as well, and you could have the opportunity to go to space. You've got retrieval medicine, so that is mountain rescue. It might be secondary transfers if you're in a very rural place working on the fixed wing air ambulances that transfer someone from a remote village to a city airport. And you've got humanitarian responses, so if there's a humanitarian disaster that needs international aid, there's all of these opportunities within medicine. And essentially, where humans go, medicine must follow. And so that is a good thing to remember with medicine, is that whatever you want to do, there is always an opportunity, and you just need to be able to think a bit outside the box and, try out different things, expand your horizons a little bit and see what else is out there. And the fact that you guys are here today listening to me talk about expedition medicine, it shows that you've taken that first step on that journey. So this is a beautiful photo from the summit of Cotopaxi volcano in Ecuador. Just the sunrise above the clouds, and our guide Tim Mosdale on the summit there. So expedition medicine, it can give you the opportunity to climb mountains, to sleep under the stars, to go to amazing places that you wouldn't otherwise have the opportunity to go to, perhaps. And so you might be thinking, how can I get involved? What are the next steps? So a really good place to start is this conference. So World Extreme Medicine are organising this conference, and it's on the 17th and 18th of October. Their booking opens tomorrow, actually, the 1st of September. So if you look at their website, which is extrememedicineexpo.com, or if you just type in World Extreme Medicine, it comes up as the top link on Google. And there's an opportunity to book that conference where there'll be lots of speakers talking about all sorts of amazing things. They've got astronauts, expedition medics, TV medics, humanitarian medics, all sorts. So this would be a really cool place if you're interested in taking the next steps. So what can you do now? Well, there's that conference I just spoke about. Also, it's about developing the skill set. So if you are going to be treating a lot of blisters and things like that, then get involved with some event medicine. So if there are assault races, there are big cycling events, marathons, triathlons, anything like that, they often supply medical support, which be through like a first aid organization. Get involved with those. join a university society. So if you've got a society for expedition and wilderness medicine, join it. And if you don't, and you think it's something that would be of interest to you guys, then one of you guys, maybe Devashish, one of you guys can actually set one up and create a university or deemed university expedition medicine society. And you can organize more talks like this. You can organize training events where you guys go out into the field and practice learning how to use a splint, how to bandage up things and do first aid. And lastly is to just get expedition experience. You guys are all in India, which is the most amazing country with so many different types of environments. So just get a small, if you have a society, get a group of you together and go on a camping trip somewhere. Do something like that, get out and experience the outdoors. These are all really nice ways to get involved. Here's a couple of useful resources. So you've got the Wilderness Medical Society Clinical Practice Guidelines for acute altitude sickness, if you're interested in a bit more about altitude sickness. It's a nice paper there. And then you've got the Oxford Handbook of Expedition Wilderness Medicine, which is the book I take on all of my expeditions. It's a really good resource. It goes through everything from medical kit planning to risk assessment to altitude sickness, frostbite, dehydration, the lot. It's a really good book. I can't recommend enough. And that is the end of the talk. So I hope you've enjoyed that. If anyone's got any questions, I'll stick around for about 10 minutes and can fire away in the chat. So we've had one question already, which is, what is the difference between expedition medicine and wilderness medicine? Are they the same or are they different? There's a lot of overlap, to be honest. There's no real difference. They are, it depends on who you speak to, but essentially they're covering the same topics. Expedition medicine and wilderness medicine essentially mean medicine in the outdoors, away from your usual healthcare support network, and so they are often used interchangeably. Any other questions? Just post them in the chat. Give you a couple of minutes. Of course, if you enjoyed today and you want to follow a bit more about expedition medicine, then please do give me a follow on @expedition_doctor on Instagram, and I'll be happy to take any questions there as well if anyone can think of anything to ask afterwards. Okay. How effective is Diamox for prophylaxis in preventing AMS? So there is good evidence for Diamox or acetazolamide in preventing acute mountain sickness. In terms of whether people use it, that's kind of a personal preference. I haven't met many guides who use it routinely. They would more save it for giving it to people when they start to show some signs of AMS. The best way of preventing AMS is to have a slow ascent that gives your body enough time to acclimatize. So you're climbing high during the day and you're sleeping low, trying not to change your sleeping altitude by more than 300 to 500 meters each night. And if you are showing some signs of headaches and loss of appetite, just to try and take an extra night to allow your body a bit more time to acclimatize. Diamox taken as a prophylactic dose of 125 milligrams twice a day can be useful in preventing or reducing the incidence of AMS. But again, it's not a substitute for using a sensible acclimatization profile where you're not changing your sleeping altitude by too much each day. So question from Devashish, would you recommend training in emergency medicine or any other specialty would also help pursue expedition medicine? So emergency medicine is probably the best because in emergency medicine, you will see trauma, you will see twisted ankles, dislocated shoulders, you'll see people with chest pain, pulmonary edema. You see all of these things in emergency medicine. So it means you're familiar with it. General practice is also a good option for expedition medicine. Lots of expedition doctors are GPs because a lot of what you see on expedition is actually quite general as well. So gastroenteritis, ear problems, conjunctivitis. So that's a good option. I think if you want to be a good expedition doctor, general practice and emergency medicine are definitely the ones to go for. However, that's not to say you can't do whatever you want. If you want to be an eye surgeon, then there's plenty of opportunities to do eye surgery around the world. There's a charity called, I can't remember what it's called. Essentially, there's a charity that essentially has ophthalmic surgeons flying around the world delivering training to remote environments as well. There are opportunities within pretty much every single medical specialty to work with organizations such as Médecins Sans Frontières, which can go and do humanitarian response as well. So whatever your desired specialty, there's always a way. But if you want to do general expedition medicine, doing adventure travel, climbing mountains, then emergency medicine is very good. It's a good question. What if the doctor becomes the sufferer of an emergency, and how will the team cope with that situation? So if this is a very good point, the doctor can always be susceptible to mountain sickness as well, or any other sort of sickness. And so part of it is being prepared yourself, taking all the necessary precautions, and being honest with your expedition leader. If you're feeling a little bit unwell, it's not worth ignoring it and just pushing on. You have to tell your expedition leader early so that you can try and make sure you're okay. However, if sometimes the doctor does come down with sickness, that's okay. There's no legal requirement for there to be a doctor on the trip, and the doctor would have to be evacuated just like anybody else. And then it's up to the rest of the expedition team, the leader, the participants, to decide whether or not they're going to continue without having a doctor there or not. So again, it will change very much from expedition to expedition. Is it difficult to acclimatize to the environment at high altitude? It can be, but essentially altitude is something that is, lots of people cope with it very well as long as the acclimatization profile is sensible. So going slowly, sleeping low every day, taking extra time is always the best way with altitude. How can one manage deep cuts or wounds at sub-zero temperatures at a high altitude? So essentially, deep cuts and wounds at sub-zero temperatures, it's the same as you would manage it anywhere else. So the first thing to note is it catastrophic hemorrhage that is going to lead to that person bleeding out and essentially exsanguinating in front of you, in which case you need to deal with that straight away. So if direct pressure on the wound isn't helping, you need to think about using a tourniquet and evacuating the patient, obviously. Assuming it's not that severe, again, it's a case of when you're out on the expedition, just putting on direct pressure, putting on a bandage, stopping the bleeding, making sure the person keeps as warm as possible with lots of layers, and then getting them down to a camp or somewhere where you can have a closer look at the wound, washing it out thoroughly. So lots and lots of water as irrigation. So drinking water, so water you've either chlorinated or got bottled water, either can be used for irrigating wounds, just irrigating it thoroughly, and then either managing it with just a dressing or suturing it up if you're happy to, or using steri strips depending on the wound, or if it's really nasty, then considering evacuation, of course. And question, what measures or medical equipment to be taken care of during trauma or panic attacks to lower the risk in such environments? So the main thing when it comes to expedition medicine, your main role as the doctor is actually to prepare people thoroughly so that people have an understanding of what they can expect, what the potential dangers are, and how they would cope in such situations. So a lot of the time on expedition, you've got a few days of acclimatization and trekking, and I'll often sit down with the participants and just essentially educate them around altitude sickness and evacuations and things like this, so that everyone's a bit more familiar with it. But a big part of your role as a doctor is to give people encouragement and positive support, and just be there for people emotionally as well as medically during these trips. Okay, so it's coming up to the hour, so I think that's probably all we've got time for. I hope you guys have enjoyed today's talk, and it's opened your eyes a bit to any other opportunities within medicine. And thank you very much to Devashish for reaching out on Instagram and asking me to do this talk for you guys. I've really enjoyed it. I hope you guys have too. And if you have any other further questions, then feel free to hit me up on Instagram. I try to get back to everyone who messages me there. And yeah, good luck with your futures. Dev, I don't know if you wanted to say anything else, but otherwise I'll go ahead and end this. I think I've recorded it, so we should be good. Thanks so much. Lots of thank yous coming through. You are all very, very welcome. So this meeting has been recorded, so I will send the recording to Devashish afterwards, and you're more than welcome to have a look at this again or share it back on another session if you would like. And yeah. Okay. All right, we'll call it a day there. Thank you very much, everyone, and all the best. Bye-bye.